Today, on the Architecture of Healing, I'm joined by Juan Guzman, Chief Operating Officer for Wellstar Medical College of Georgia Medical Center, which includes the Adult Academic Medical Center, Wellstar Golisano Children's Hospital of Georgia, and the Georgia Cancer Center, and a broad ambulatory network across the Central Savannah River Area. Juan brings a deeply practical and people-centered view of healthcare operations. In this conversation, we talk about what it really takes to connect strategy with day-to-day execution inside a complex academic medical center, how leaders can build trust through rounding, listening, and following through, and why access, affordability, and care closer to home are becoming central to the future of healthcare delivery. We also explore capital planning, facility decisions, ambulatory growth, AI, and the ongoing challenge of designing systems that support both patients and the teams caring for them. For healthcare leaders, planners, designers, and strategists, this episode is a reminder that operational excellence is not just about dashboards and metrics. It's about people, place, purpose, and creating the conditions for better care to happen. Let's get into it. Welcome to the Architecture of Healing. Today we've got Juan Guzman joining us. Juan, welcome to the show.
Hey, thanks for having me, Chase. I appreciate it.
Juan and I go way back, so I am so excited to finally get you on, hear your perspective on healthcare design, strategy planning, and all those good things.
You know, it's funny you say that. I was reviewing some of the things you passed along ahead of time, and we met in 2016. So we are celebrating 10 years of friendship here, which is really cool to think about. It's been a decade now since we worked together, all the way back to our time at Indiana University Health, and you were at a prior organization and helping with an expansion of a facility. So it's cool to kind of come full circle and be a part of this. So thank you.
That's so wild. I hadn't realized it'd been 10 years. Wow.
Yeah.
Awesome. Can you share a little bit about what your role is now? I know you've recently made a change, and I'd just love to maybe unpack a little bit about what you're doing today and your current role.
My role really right now is serving, honestly, the team here at Wellstar Medical College of Georgia Medical Center, which the Medical College of Georgia Medical Center encompasses three large components. One, the Adult Academic Medical Center. The other thing that it encompasses is the Wellstar Golisano Children's Hospital of Georgia and the Georgia Cancer Center. So joined the team about 4.5 months ago now, which is really, time flies when you're having fun is what everyone says, right? I've had a blast here so far. Such a great team, a big sense of responsibility, being one of only a few academic medical centers in the Georgia market and the only academic medical center in we call our market, the Central Savannah River Area market, CSRA. So have oversight of operations for those large facilities, serving as the chief operating officer here, but also have some ambulatory oversight of about 80 outpatient ambulatory locations across the CSRA too.
What does that look like for you as a chief operating officer? We say that word, right? And it's chief operating officer over this. And it's like, wow, that sounds big. That sounds like it encompasses a lot. And
Yeah.
I honestly think when people hear that, they hear different things and they have their own perception of what a
Yep.
chief operating officer does.
Yep.
So I'd love to hear from you. What does that look like for
That-
you and kind of a day in the life?
Yeah. Last week I had the opportunity and the privilege of rounding with our respiratory therapy team and our pulmonary function team. And someone jokingly said, "Oh, you run this place." And I think I more eloquently described it as, no, this place actually runs me as a chief operating officer. And so I think for me, it boils down to really working in partnership with our chief medical officer and chief nursing officer as a triad to ensure the day-to-day operations of this facility run the way they need to, and making sure that we are driving the best possible team member experience that entail gives us the best possible patient experience as well. And so for me, it's day-to-day operations. Chase, for us, we are in the midst of redeploying an operational management system, or redeploying, I should say, an operational management system that will really govern how we do the work here. Things like monthly operating reviews, leader standard work, making sure we're doing our leader rounding, our tiered huddles, visual management system. So it's making sure that the integrity of our operational management system is what it needs to be, and then focused on where are we headed. So I always tell folks the COO is always kind of in the middle of kind of the strategic and in the day-to-day operations, and making sure that we can connect the dots and get to our strategic vision by ensuring that we pull and create healthy tension for our operational teams to really drive towards that strategic end game that we're all after. My role really right now is to drive the operations, make sure that our team is developing to the point where we understand our business, what are the drivers, and really elevating those things that we need to elevate in terms of patient outcomes and patient experience by supporting our teams. It's been a huge journey right now. I think this is much different than the prior role that I had where everything was in one location in terms of one campus. This is a large academic medical center that has locations across multiple city blocks and obviously locations across the market that we call the Central Savannah River Area. So I think right now I'm also learning how to bend and how to be more agile and adaptable in my own leadership to be able to one, create a presence, but then two, to be able to spend time with the team and learn from our patients across the market, not just in one location.
Yeah. Yeah. Getting your steps in, walking all across all
Yeah,
day.
that's what, since moving to Georgia from Indiana, I will tell you one thing that my Apple Watch has told me is I'm getting a lot more steps in. So I guess that's a blessing.
You talk about blending strategy and operations and taking these strategic goals and deploying those operationally and that healthy tension. Do you have an example of what that looks like from taking this goal that's out there and operationalizing the teams in order to meet those system-wide strategic goals, so to speak?
For us right now, one of the big things that we're working on, Chase, is defining our identity and creating an identity. And one of those things that we know is super important for us is we have to continue to meet the needs of all of the residents across Georgia as an academic medical center. We know that Georgia has a large metropolis known as Atlanta, right? And the metropolitan area of Atlanta that has about 6 million people living in it. But there's another 6.5, 7 million people living outside of Atlanta in the greater Georgia area. And to be frank, not only do Hoosiers like myself like to avoid the traffic inside of Atlanta, but so do people who live outside of Atlanta, inside of Georgia. They also like to avoid the traffic inside of Atlanta. And so there are folks in Macon, there are folks in Savannah, there are folks in even, South Carolina that would prefer not to drive to large metropolitan areas and come to locations like Augusta for highly specialized tertiary quaternary care. And so our vision and our strategy has been, how do we reach those people? How do we reach those patients? How do we reach those individuals who we know could trust us with their care outside of the Atlanta metro area, perhaps even, and make things easy for them? And some of those things strategically for us and service lines for us have been oncology, transplant, and even there's some other neurosciences services, Chase. And so the vision has been, how do we reach them? The strategy is, how do we create outreach for them? But then third, how do you operationalize something like how do you ensure that your team knows that they're going to have to get up at 3 in the morning and drive down to Macon, or get up at 4 in the morning, get ready and drive to Savannah, but it's all for a greater purpose. And right, you have to really think about those team members a little bit differently and ensure that you are setting them up with the right infrastructure, whether it's compensation, whether it's travel, lodging, those types of things. The outreach looks different than perhaps coming to a home base every day, day in and day out. We just cut a ribbon on a new transplant clinic that is doing outreach in Atlanta. We have a transplant clinic that does outreach in Savannah as well. We have our bone marrow transplant team that does outreach to Athens, soon to be Macon, and looking to go elsewhere as well, right? Because we know the closer we can keep our patients to home, the better off they're going to be. And so I would say for us, it's really understanding what it's going to take from the team to operationalize those things and making sure the team is set up with the right infrastructure to achieve that strategy that you're after, which right at this point is, how do you bring some of this specialized tertiary quaternary type care closer to home?
I would imagine that tension starts to pull on itself when your operational teams are really succeeding and doing well. However, resources are limited and
Yep.
you continue to pour into that and they're doing well, but then you're sacrificing other goals maybe on the back end because the resources are constrained perhaps, and
Yep.
you need to focus on a number of things simultaneously, right?
Definitely.
So you've been at Wellstar almost 5 months, stepping into this new market, this new organization. Were there things that you maybe had to unlearn or rewire about how you work to be effective quickly?
There were probably 5 to 6 big things, Chase, as I was making the transition over into Wellstar that were very important for me. I would say the book, The First 90 Days, is a great recommendation. But there were a couple of things for me that I had to unlearn and relearn here. And I tell folks it's all part of this kind of journey of deciphering the matrix. We live in a very complex world. At times, we as humans can and make it complicated. But these large health systems like Wellstar Health System, there's complexity with them. There's a matrix within them. And then you, on top of that, add in a layer of the academic world, such as the Medical College of Georgia, which will soon be the third largest medical school in the country by enrollment. There's a matrix that you have to decipher. You have to understand. So for me, I had to first unlearn and rewire and relearn people. Healthcare is a people business at its core, but the two people I really needed to know and understand were the team here locally and understand what motivates them, what drives them, what are some of the challenges that they've had over the course of the last few years leading up to my arrival here, and understand how I could best support them. Not only support them in the work that they're doing today, but also help support them in the work they want to be doing in the future and how they want to grow and develop as a leader and as a leader within healthcare. The second aspect of the people I had to kind of unlearn or rewire for me was the community and our patients. Going back to what some of my past mentors have always told me, healthcare is local. Really, it is. Care is local. And I think you have to really understand the needs of your patients, right? I was at an organization and facility that was a suburban, affluent, growing community and had a really strong, I would say, comparably payer mix compared to the current location that I'm at here at Wellstar and CG Health. And the needs of the populations were different and they will be different. Now, they were similar service lines, right? If you think of oncology or musculoskeletal, even cardiovascular services, but there are different social aspects that you have to take into consideration as you're building your strategic plan for your facility. And so I think first and foremost, I had to unlearn and rewire to the people, both internal to Wellstar MCG Health and the greater health system, but then also to the greater community and the patients that we're serving. I think if you were to ask me organizationally, what did I have to unlearn and rewire to? It's things like the pace of an institution and the pace of an organization. It's things like decision-making pathways and how are decisions made, even levels of authority and matrix reporting structures. How does Wellstar as a whole make decisions? And how does Wellstar Medical College of Georgia make decisions? It's important. And I would say the last but not least aspect that I had to unlearn or rewire to be effective, Chase, was the historical context. Wellstar Medical College of Georgia has only been a part of Wellstar as a health system for about 3 years now. And so relatively new as an entity within the greater Wellstar health system. This is Wellstar's first entrance into the academic medical center world. They have really strong programs in Kennestone from a GME standpoint, et cetera. But this was the first time they were partnered with the Medical College of Georgia in such a robust fashion. And I think understanding the historical context, understanding why this relationship came to be, understanding what led to this relationship even being a possibility was really important for me. The first 2 to 3 months of my time here has really been focused on just learning and understanding how we got to this point and what the real vision was when we began these conversations and how we can continue to elevate care in the Central Savannah River area.
So as you have taken all of this knowledge that you've been absorbing over the last 5 months or so, and you look forward, when you think of the term operational excellence,
Yeah.
and you see traditional KPIs, what does that look like for you? What are you measuring? What are you tracking to determine success, say in some of those strategic endeavors that you are pursuing as it relates to translating that into your operations?
You know, it's so fun. You're going to hear throughout this conversation a lot about people from me. I mean, I think, and again, great mentorship in my past, and I've had the fortunate privilege of really being surrounded by what I would say were some great healthcare leaders, both in Indiana and now even here in Georgia. But for me, healthcare is a people business. And so as I think about operational excellence, the first thing that comes to mind, and I've had this conversation with the team here locally, is people development and developing your people. KPIs like first case on time start or OR, prime time utilization or, number of patients per room, per clinic, per day, or per session. Right? Those are hard metrics that really most folks think about continuous improvement in driving the outcome. Operational excellence for me today is more about how are you developing your leaders and understand and developing the people who are caring for our patients to truly understand care delivery at its most granular level, and how are we continuously improving that. I think I'm reading a good book right now called The Slight Edge, and it talks a lot about mastering the mundane and getting slightly better every single day and having that discipline to do that. No matter how small, insignificant the habit is, it builds on itself over time, kind of like this compounding interest type of metaphor, I guess you could say. And so for me, operational excellence really means, what is your operational management system maturity? And how is the team accustomed to managing those operations to measure the right things, to drive progress in the right areas so that you can deliver ultimately on your strategic outcomes, which should start with your patients. It should start with a great experience, high quality experience, and ensuring that we're always keeping the patient at the forefront of everything that we're doing. Operational excellence is, how are you developing your team to be able to do that? How are you ensuring that there's maturity in how people are problem solving, how they're doing their work, and it's data driven, it's outcome focused, and people centered all the time.
I love hearing you talk about people. This has been a recurring theme in a number of episodes that we've had where the patient experience is driven so much by the interactions we have with people.
Yeah.
And you remember the nurse or the physician and the way they talked to you and the things they communicated to you and the way they treated you with respect and dignity, just as much, if not more, than the outcome itself.
Yep.
The way that you drive that through the organization is so impactful. And as you lead other people and pour into other people, it's those people that are driving those KPIs.
Definitely.
And when they're motivated and they're inspired to do good work and rally together as a team, it just makes everyone better. And then
Yep.
ultimately the patient. So I love that.
Yeah, it's interesting you say that. I had the privilege of sitting in new leader orientation and then sitting in orientation here locally. It's the first time I had done an orientation in 10 years. So I was kind of giddy and anxious about, okay, am I going to really fit in with folks? And I will boil it down to two words that my leader in my current role said at the opening of orientation: be nice, be nice. People will remember how nice you were to them long before they're going to remember what their diagnosis was, what their next step in understanding what their diagnosis is or was, what their surgical outcome may or may not have been. They're going to remember if you were nice. And that means it's about people. But a world where right now there's a lot of angst around AI and what that means for people. I will tell you, healthcare is a people business, and we're going to need more people to care for more people. And I think for me, there's just no substitute for that human
Yeah.
connection. That
So
is what
good.
people remember here. And I think we have to get it right as healthcare to make sure that we invest in our people so that they can take great care of people.
What does it look like to get it wrong?
It's a great question. We've had this conversation with our chief medical officer. He's the one that actually brings it up. Dr. Cool's fantastic at kind of, you have to unpack the entire patient. It's a human being at the end of the day in front of you. It's not just a diagnosis code, right? There are so many aspects to this human being, particularly social aspects of their life, that really determine to a great extent their entire health outcome. What does their home life look like? What does their family support look like? What does their methods or modes of transportation look like? We are working right now on throughput in our facility. And I think most hospitals across America right now probably face throughput challenges. And we're finding quickly that the patients who are here for a long time and maybe don't need to be here for as long as they aren't really necessarily facing a medical diagnosis problem. They're facing a social problem. And how are we as organizations going to help support them? And so I'd say perhaps not health systems getting operations wrong, but more so, how are we appreciating the fact that right now the perception of many of our patients are that we exist as hospitals to solve all of our patients' problems, not just those that are medical. I think patients have certainly increased in medical complexity, but more challengingly, they're also increasing in social complexity. And that puts pressure on the hospital to think about the entire continuum of care inside and outside of our four walls and how we serve as a conduit for resources. There was a mentor of mine that once used to say, you can't be everything to everyone all the time. You can't afford it, to be frank with you. But the question becomes, how do you begin to partner with entities outside of our four walls to be able to be the master conduit of living a healthy life for our patients, which is exactly what we're trying to do. Some of it is about equipping our ED with social workers and case managers so that we can ensure we drive down 30-day readmissions, et cetera, whatever it may be. But also part of this is how do we think about our aging population? How do we think about our population with multiple comorbidities a little bit differently and think about our role as a little more expansive and being a conduit more than anything. And so it's not necessarily that we're getting anything wrong from an operation standpoint. It's more of that our operations are changing and are we
Yeah.
adapting hospitals as well to be able to meet the needs of those patients?
One of those needs is this continued shift towards more outpatient based care.
Yeah.
As the industry continues to shift that way and distributed care, alternative sites of care, how do you think about that balance between hospital based care and ambulatory growth in terms of strategic thought processes or operationally?
If you were to give me a crystal ball and I were to look into it and tell you what the future of hospitals looks like, I would say a lot of the clinicians that I've interacted with would tell you our patients inside the four walls of our hospital are only getting sicker. There is a shift towards facilities and hospitals really being more tertiary, quaternary sites of care. And you're no longer going to need the hospital for what I would say routine, preventative, secondary type of care. Think of a joint replacement of the past. I had an uncle who had both of his knees, bilateral knee replacement, about 12 years ago now. And he stayed in the hospital for about 7 days. That was his inpatient stay. I would tell you, I'm guessing there's someone out there right now doing bilateral knee replacements on an outpatient status, and folks are going home same day. And for my family, my father had both of his hips replaced, lived in one city, traveled 2 hours for his hip replacement. And within the same day, traveled back home, was discharged, and was at the dinner table with a brand new hip 2 hours away. And so it tells you that the advances of medicine have gotten so great to the point where these big hospitals are truly becoming a place where you have to care for some of the sickest possible patients, which means that we have to be much more integrated within our communities from a primary, secondary services standpoint, Chase. And so moving ambulatory surgery centers and growing those types of sites of care, growing the ambulatory footprint to be closest to the rooftops, which means closest to our patients, is really important. And it's the journey that we're on here at Wellstar MTG. We're really trying to look at how we can continue to grow closer to home for our patients so that not everybody has to drive to downtown Augusta, Georgia for all aspects of their care. Even to say we're building a new hospital about 15, 20 miles west of here, not even, to ensure that our patients in the Columbia County market can receive the care they need from Wellstar closer to home, and having some of our highly specialized team members go back and forth between here at the Academic Medical Center and there as well. I think you're going to see a much more intentional and much more, I would say, spread out care model in the future where not everyone will need to be here. I would also say, Chase, we talk a lot about healthcare in the inpatient and the outpatient world. We should really start thinking about it in almost three senses. What is the hospital? What is the ambulatory footprint? What's our digital network footprint as well? So
Yeah.
hospital at home, EICU, our telehealth services, our rehab at home types of services, at home infusion services. I mean, it's really interesting, right? The care of the old days, well, I'll say centuries ago, was the doctor would come to your house and he would
Yeah.
check up on you. And then all of a sudden we built all these hospitals and now everybody had to come to the hospital. And now we're kind of moving back to that model. This pendulum is now swinging back to what more can you take at the house, at the home or closer to home where folks aren't having to be at the hospital.
So true. And that makes me think of a question around access and affordability because
Yeah.
as you grow access and you create spaces to improve access in maybe suburban or more rural areas, you you in some senses maybe drive cost a little bit upwards because you're spreading your resources more broadly. Is that something that you wrestle with in terms of how do we provide this better access but also make it affordable?
Access and affordability are always top of mind for us. I think the reimbursement model is forcing us on this, right? We are healthcare reimbursement has been changing for years, whether people like to believe it or not. It has been, and everything from the 90s to the Affordable Care Act to now kind of having the OBBBA legislation. There have been changes in legislation that have led to reimbursement reductions across the board. Therefore, we as health systems must figure out how to deliver more cost-effective options to our patients that will allow them to receive the clinical outcome and the quality of life that they deserve. And so for us, access and affordability are always top of mind. The changing reimbursement landscape is forcing that, right? It's forcing our hands to do that. Not that we shouldn't have been doing it from the get-go, and we have been here at Wellstar. Access has and will continue to be the battleground, Chase. We know that access to healthcare and preventative care and secondary care drives long-term outcomes for patients and populations down the road. If you're seeing a primary care physician, if you're doing your mammogram every year, if you're getting your preventative care on a routine basis, we know you're going to have better outcomes down the pipeline. If you are in a healthcare desert, you're going to have not as great outcomes. There was a physician at my prior organization that used to always say, patients care about these three things in this rank order. Are you accessible as a physician? Are you affable? And then are you capable? And I thought that was really interesting because he as a physician leader used to say, they don't even care if I graduated at the top of my class. They just assume that I'm a doctor by the two initials at the end of my name. They don't even care nearly as much if they can get along with me, i.e. being affable. They care most about whether or not they can get in to see me when they need me. And so
Yeah.
access to me is really that next battleground, but has been the battleground for years for our patients because, or for healthcare on behalf of our patients, because that's what patients care about. Even our physicians here, accessible, affable, and capable, and really thinking about those.
Well, that's really insightful. Very insightful.
Okay.
As you continue to grow through some of these alternative sites and moving towards the outpatient environment, how has that provided opportunity on your acute care campuses and allowed for more specialty, higher acuity type services to backfill some of those spaces that maybe be extending out into other areas outside of the main campus?
This is a journey we're on right now at Wellstar Medical College of Georgia Medical Center. We have large clinics right now, Chase, on our campus that are our primary care, secondary care type of services where, as a consumer of healthcare myself, along with many of my family members, we don't want to drive to a metropolitan area for this unless we have to. We're going to find other closer alternative care sites. And so I know in my prior organization, one of the things that we focused on was we really tried to understand our philosophy on what belongs on our campus from a medical office building standpoint and what honestly belongs closer to our patients. I know at one point our facility, particularly the medical office building attached to the hospital at my prior organization, had quite a bit of primary care presence inside of it and not as much specialty care as what we knew was needed in the community. And so we had to sit down with our physician leaders, sit down with ourselves really and look and say, what are we going to become on this campus and off this campus? And what's better for our patients? And over the course of 4 years, as I served as the COO there, we had quite a few restacks with our medical office building that really forced us to think differently about primary care being closer to our patients in the community and off of our campus. By the time that I had left, I think we had maybe 2 or 3 primary care clinics on our campus. And when I had started, we had probably close to 5. And we were able to restack our medical office building to create additional capacity for things like neurology, orthopedics, spine, urology, and some of those highly specialized services that our patients need on our campus. I think we're going to probably go through a similar exercise here where we try to understand what belongs on our academic medical center campus and what does not belong here. And if it doesn't belong on our campus, where does it belong? Where are our patients that are coming here for this service? And where should we be able to meet them closer to where they are at? I think it helps us drive the patient experience, but it also helps us drive team member engagement. The why behind that is a lot of our team members are a part of the community and they're also coming here for services and whatnot. If you are not able to be accessible for your team in the community and they're always driving down to the academic medical center for their services, they're also patients as well. So that patient experience that it helps drive is important. The other thing too, Chase, is it drives our ability to be as lower cost as possible. Delivering services on an academic medical center campus is not cheap. And we have a very expensive infrastructure and overhead, and we know it. There's only about, if you were to ask Vizient, there are about 120 academic medical centers across the country that are in the Vizient compare groups. There's probably a little bit more than that, but let's just say there's less than 150 academic medical centers. They're expensive to run. So
Yeah.
how do you decant some of these services to more appropriate sites of care? And then how do you grow that specialty, tertiary, quaternary type of service? How do you grow a bone marrow transplant program? How do you grow your kidney pancreatic transplant program? How do you grow your neurosciences program, your spine surgery program, et cetera? The things that do belong on our campus, as you begin to decant things, then you can begin to re-envision, reimagine what belongs on your campus and how you grow that as part of your identity and your destination medicine efforts.
You started to touch on this topic, but thinking about those academic medical centers with this high cost to maintain and operate, how does capital planning factor into your role and thinking about how we allocate capital spend over time to improve our facilities to maintain and to expand?
I'll be honest, I have had the blessing of working with some of the best CFOs in my career. Had a great CFO partner at my prior organization for the longest time, and she was wonderful. And I have been blessed to have a fantastic CFO here at Wellstar. She has just been a super rock star, a breath of fresh air. It's been so much fun. And I would say the two of us have been just tied to the hip, Chase, as it relates to capital planning. Her and I focus on a couple of things. There's a few philosophies that we both have as it relates to ensuring our capital plan is supporting the growth of our team and growing the support of our patients. First and foremost, back to the overarching conversation we've been having, it starts with listening to your team, listening to your people, and rounding with them, understanding the friction points that the lack of capital or infrastructure has created and finding the solutions, making sure that you listen to people, the team and the patients before you make any capital decisions is important. And I would say since I've started here at Wellstar MCG in January, the CFO and I have been doing nothing but listening sessions. She has joined me in rounding sessions. Her and I have been working with our facilities partners and really listening to the team on what breaks if we don't fix it tomorrow. And how does that preclude us from doing what we need to do, which is take care of people. And so we've really been taking that philosophy of just listening. The other thing too, Chase, is we've been working really hard to pressure test that your planning efforts for your capital do not create unintended consequences in the future. You always want to minimize unintended consequences, and especially as it relates to capital, because it's so limited that if you're almost certain that there could be a fatal flaw in future planning if you do construction in one area versus another, you want to make sure you avoid those things and really drive financial stewardship. Because, like I said, capital being so limited, you have to ensure that you're a great steward of the financials that have been allocated to you, whether it be it from a large grant, whether it be it from system routine capital allocation or through a strategic project. You have to make sure you safeguard it to have the most impact to our patients. And so we have really worked hard to pressure test our plans, with a fresh set of eyes. We're getting ready to embark on a pretty cool journey down the road, hopefully on a master facility plan. And I think this will help us be better stewards of our resources, better stewards of our capital plan, because it's really expensive to get a mulligan, no pun intended, living in Augusta, in healthcare capital. It's really
Yeah.
expensive. And that's one thing you don't want to go back to the well for ever is, hey, we actually put this department in the wrong location. We want to now relocate it 4 years later and we'll put a different department there. How do you think about the entire continuum of care within your facility? How do you think of the entire space flow optimization of your facility and how it cares for the people it serves and make sure it does it in the most seamless way possible? Large academic medical centers across the country, most of them aren't brand new. Those that are brand new are very fortunate to be in that kind of state, but most academic medical centers are a compilation of different facilities that were developed at different time periods with different architecture. They're very eclectic if you kind of spend some time
Yeah.
actually learning them. And so you have to work with what you have in the absence of being able to build something brand new and having a blank slate. So making sure that you listen to your people and then making sure you work really hard to pressure test any of your planning efforts so as to minimize any future unintended consequences is really important, but also continue to drive growth.
Interesting that you bring that up. I was working with an organization that they have a department on the fourth floor, and a clinic adjacent to it had closed after COVID. And this department said, "Hey, we need more space. Let's just move into that space." And it wasn't great. It was kind of fragmented and not super well located.
Yep.
But then I asked the department director, said, "If you could be anywhere in the hospital, where would you want to be? And if it's here on the fourth floor, that's great. Let's talk. But where would you want to be?" And the
Yep.
answer was, "Well, we want to be on the first floor." I'm like, "Okay, I think you need to be on the first floor too. Let's figure that out and not,
Yeah.
double down on this fourth floor space."
Yeah. It's so funny you see that, right? People, when space becomes available in any type of facility, folks go after it just because there's relatively or rarely ever space to grow
Right.
into, regardless if it's the right place or not, right? For the patient and for the team. It's like, well, we'll make do of it. And to your point, I probably it's what you're getting to. And I'm sorry I cut you off here, but you're probably
No.
getting to what's the best flow for the patient? What's the
Yeah.
best flow for the team? And just because it's empty space doesn't mean it's the right space.
But it's so true. I mean, do you throw good money after bad? And how far do you go before you stop, take the time, and reallocate appropriately? And so there's this dynamic to the patient flow, but also operationally, you've got a building and then the operations. And in my mind, I like to say we figure out how the space and how the teams need to operate, and then we'll create the building and the
Yep.
facility around it. But
Yep.
so many times we've already got the facilities. There's so much infrastructure. There's so much building that's already there, to your point, of these kind of disconnected types of architecture that are hodgepodge together.
Yep.
How do you align operational flows in a meaningful, efficient way to some of these fragmented spaces and this existing building?
One of the things I really challenge our teams to do, and I would say it at my prior organization all the time, was I used to challenge our teams to look up and out and beyond our four walls. And I think for me, Chase, what that means is get out of town and go see how someone else does this, whether that's at a conference, whether that's a benchmarking trip at a different organization, whatever it may be. We're all in it for the right reasons. If you're in healthcare, you're in it because you want to care for people. There's this innate competitor mindset that we have right amongst organizations. But when rubber meets the road, and if we knocked on the door of one of our competitors and said, how do you work through throughput in your organization? Or how did you lay out the flow of your ORs, pre-op, post-op PACU areas? I guarantee you all of them are going to say, yeah, come on in. Let's take a look. We'll show you what we've learned so far, and maybe you can share things with us. And so whenever you're looking to redesign workflows, whenever you're looking to kind of think about how you improve things for your teams, I've always asked individuals who've reported to me and even our executive team and challenge them to say, look up and out, look beyond your four walls, go and visit somewhere. I don't care. A $500 round trip plane ticket is pretty darn cheap if it's going to save you $5 million on the back end by designing the
Yeah.
right for our patients and for our teams. And so get out of town, go have a conversation with a colleague that you met at a conference in Arizona, go have a conversation with a colleague you've met in Chicago or, Florida, or wherever it may be, connect yourself with others in the industry to see what they're doing and how can we steal shamelessly some gold nuggets here or there to make our product for our patients the best it possibly can be.
Rising tide lifts all boats. And so as
Yep.
we're sharing those notes and comparing, we're all getting better. And similarly, you're going to get the call from the place you go visit a couple
Yep.
years from now. They're going to want to come see what you did and what you took, right?
Yep.
And then they're going to take that back and make their systems better. So you mentioned rounding. What does that look like when you round with providers, physicians, with your teams? What does that look like for you?
Intentional rounding or leader rounding is part of my leader-centered work. So every month I am very protective of this. Even as my administrative assistant, who's fantastic as well and has been supporting me now for 4.5 months. There are times where, hey, can we cut off your rounding here? Can we reschedule it? I'm like, no, you can't. And so what it looks like for me is I don't like surprises. I'm not a huge person that's going to get you, type of deal. And so I always invite the leader of respective areas that I am planning to round on rounds with me. It's very intentional. And most of the time, Chase, there's two people that I want to talk to. I want to talk to our frontline teams and I want to talk to our patients. Have had a chance to round in the ORs with our teams and have gone into PACU bays and had conversations with patients on why'd you choose us? Why have you trusted us with your care? And how do we do today? And yeah, I have a team of 3 or 4 people that are with me that work in this area. Be honest with us, because that's the only way we can get better. When I round with our team, a lot of times you're going to hear me asking questions like, why are you here? How is this part of your journey in life? And where are you at Wellstar? Why do you stay? If you're here, it's one thing to ask you how you got here. It's another thing to ask you why you've even stayed. And I've learned a lot about people who are very tenured at this organization and the sense of responsibility they have to continue to elevate care here, not only for the local community that we serve, but really the greater Central Savannah River area. And then the other thing I always ask folks that I think catches people a little bit off guard is, what can we be doing better as the executive team? What could I be doing better? What can I work on? What do you need from me to be able to take better care of patients? And what do you need me to do so that you can be at your best when you're caring for people? And then I would say the rounding doesn't stop there at that conversation, Chase. It really is about the follow through. What happens after the fact? I had a chance to round with our EVS team last week, and they were excited about me rounding, I think, or so they acted like it, I guess you could say. And they were actually most excited to show me how small their break room was. We have a little over 190 FTEs for EVS, and I guarantee you their EVS break room doesn't fit more than 15 people in it.
Wow.
And so if we're asking them to be the first line of defense in our quality and safety mission, which is making sure our rooms are cleaned every day, which is making sure that our discharge rooms are terminally cleaned the way they need to be to drive down the spread of infection, why don't they also have a break room that mirrors their level of importance? And so it's things like that that you find out in your rounds. I had the opportunity to spend a little bit of time with our pathology team and learning about instrumentation and the need for them to interface with our broader kind of network and the issues that they have there, and making sure that they have the support that they need, reaching out to our system IS team, lab IS team to make sure that that connectivity is there. I had the privilege of rounding in our general surgery clinic here at the campus a couple of weeks ago, and they were excited to show me how old their exam room tables were. And guess what we had the privilege of approving last week was you get 3 brand new exam room tables. And it's
Nice.
that follow through of rounding
Yeah.
where people can say, you know what, I have a voice, right? When the executive team walks through here and they round, they hear us and they actually take action. And that's really what helps drive what, Wellstar really calls, people care. It's really, it's making sure that it's taking care of your patients, but also taking care of your people. And it's also about, right, driving that trust score and driving trust between our frontline teams and our executive team. And Wellstar has been so privileged to be a part of Fortune's top 100 places to work, one of the very few healthcare organizations that has that. But I think it's that culture that it has of making sure it listens to the team, taking care of our patients, and then driving change associated with it. Last year, one of our great place to work opportunities was there wasn't great meal options in the evening hours or weekends. And so lo and behold, a year later, this past February, we opened up a micro mart for our teams. And it probably has a better selection than what I walked through the grocery store yesterday in terms of fresh fruits and vegetables. Holy cow, they have nutritious food at their ready as team members. They can badge in, getting a fresh meal on a Saturday night, getting a fresh meal on a Sunday morning when everything else is closed because our other team members needed to have a respite day as well. How can we ensure that they have what they need? And a lot of that is continuing to build trust. I tell folks,
Yeah.
number one thing you can work on as an executive is get out there and talk to your team. It builds trust, it builds rapport, and it's something that builds over time. And that team will go to fight for our patients every single day if they trust that the executive team is moving them in the right direction and listening to them.
I need to sign up and come round with you. That sounds
I'm in.
awesome.
Our VP of HR just started joining me last week, and it's been a blast.
That just sounds like such a fun, rewarding experience just to be able to have that interaction on a regular
Best
basis
part.
and
Yeah.
talk to the patients, talk to the staff, and
Yeah.
just be there.
Yep.
Yeah.
Best part of my job is rounding. And like I said, I've got about 17 direct reports right now, and I spend at a minimum 17 hours a month out there rounding with the team. And that is where
Nice.
80% of my work comes from.
So we're coming around home here. One question I like to ask everyone on the show: if you could redesign or change one space, system, or component in healthcare, what would that be?
It's funny when I read this question again this weekend, I was like, my goodness, I've heard this question before. And I actually had the privilege of speaking at Becker's annual meeting this past spring in Chicago. And this is the exact question that was asked of us as a panel. And so I'm going to stay true to the answer that I gave the group in Chicago that came and listened to my panel. And it would be the one thing I would change, Chase, is ensuring that we had incentives more aligned across the entire industry. I think you have really large silos right now in healthcare in general. You've got pharma, you've got, health systems, you've got the third party payers, insurance. And I mentioned this earlier. There are so many more social aspects of care that impact an individual's health outcome that the three of those big industries that I just named don't really touch, or at least have not traditionally touched. And so how do the payers of healthcare, the consumers of healthcare drive the alignment of incentives to ensure that we're working more closely with all partners who can impact health outcomes? In my prior organization, there was a lot of work around community impact and investment, and really using foundation grants from the organization to, I would say, elevate small not-for-profits around the community back to care being local. Down in rural Southern Indiana, making sure that there's access to behavioral health services, making sure there's access to services in Southern Indiana for individuals who happen to be homeless at the time, or making sure that there's access to services for individuals to achieve higher educational attainment. All of these things working more and more unison will create for a healthier society, a healthier community, anywhere and everywhere that you can be. And so how do we align those? How do we align pharma? How do we align healthcare with those other ecosystems of social services that can help really elevate health and elevate well-being for people, so that we can really honestly drive patients as far away from hospitals and closer to the most healthy kind of lifestyle possible, and really not be looking at our P&L every month and saying, wow, our volumes were off this month. We need to go find more hips and knees to replace. Wow, our volumes were off. We need to do more cardiac cath procedures. But how do we work with everybody to make sure that our community has access to great food? And, this food is medicine type of mindset, making sure that, pharma is able to provide the right medications for people so that they aren't readmitted in the
Yeah.
future. And so really, if I could change one thing, it would be, how do we realign incentives so that not only the three current traditional pillars of the healthcare industry work closely together, but also work with other ecosystems that are driving health within communities as well. And ultimately, obviously driving things at our legislative level too, to make sure we drive some of that.
Yeah, it's funny you talk about food as medicine. On a previous episode, I was talking with a guest about food and how it could be almost prescribed like medication. And okay, can I go down to the equivalent of CVS or Walgreens and pick up my nutritional lunchbox, so to
Yeah.
speak, or like healthy meal? Because I live in a food desert and I don't have access to fresh fruits and vegetables. How do I
Yep.
get that? Because I'm on this medication that needs me to be healthy in order to
Yes.
take this medication. It's such a unified approach that we need to shift to, as you mentioned, all these siloed areas that just need to start to talk to each other.
Exactly. Exactly. We're all in it for the same thing. It's just more of we're all being incentivized differently for it. And
Yeah,
so how do we align those?
for sure. So, lightning round. Let's go.
Okay.
What is one of your favorite healing spaces?
So this isn't very lightning of me. Cancer Center, ever since I had the privilege of serving as a regional service center leader for cancer in a prior organization, have always seen the depth of the relationships that our care teams have in the cancer center, and how they get to really know our patients at the most granular level and the most vulnerable times. But I would say a close second, overseeing the Wellstar Golisano Children's Hospital. The Children's Hospital is pretty darn cool too. So
Yeah,
I would say Cancer Center and Children's Hospitals have been really, really cool.
nice, nice. What inspires you outside of work?
Oh man, this was so my family first and foremost. So daughters, parents, loved ones. I mean, my family really is what keeps me going every single day. So they are my rock.
Love it. What is a book that has changed the way you think?
three books that I would strongly say had a big influence on me. First of all, The Gifts of Imperfection by Brene Brown. I'm reading The Slight Edge right now. A fantastic book as well. And then a third book that I just finished up reading about 3 or 4 weeks ago, The Courage to be Disliked.
I will link to those so anyone listening can find those books quickly. And finish this sentence. The future of healthcare is blank.
Bright. It's bright. Yep.
Awesome. I think part of why it's bright is because of the people that are in healthcare doing the hard things. Like you touched on it, talking about people, and I couldn't agree more. There are so many amazing, incredible people, frontline caregivers, healthcare leaders, consultants, everyone across the spectrum doing really great things and all doing it for the right reasons. So
Yep. I would echo everything you just said. It is one of those things where the more and more I get to meet people in healthcare, whether it's at a conference, a new organization, my prior organization, Chase, everyone's in it for the right reasons. And for that reason, I will tell you, there are a lot of unknowns in healthcare right now, but the one thing I know for sure is great leadership is going to get us through this. And all I am surrounded by right now across healthcare seems to be great leadership. So I think we've got a bright future ahead of us.
Well, thank you so much for joining us on the show today. This has been so much fun to talk with you and just learn more about your role and all the exciting things that you're doing. So thanks again.
Awesome. Well, I appreciate you. Thank you so much. Thanks for having me.
And let me know when I can come down and do some rounding with you.
That's right. Not only that, you got to come down. We got to get you back to Augusta National. I know you've been before.
Absolutely. Let's go.
What I appreciate most about this conversation with Juan is how consistently he brings healthcare back to people. Whether he's talking about operational management systems, capital planning, ambulatory growth, or AI, the through line is clear. Strategy only works when it's connected to the lived experience of patients, clinicians, and frontline teams. Better access, smarter facility planning, and more effective operations all depend on leaders who are willing to listen, round, ask better questions, and act on what they hear. For those of us shaping healthcare environments and systems, Juan's perspective is a powerful reminder that the built environment is not separate from care delivery. It either supports the work, the flow, and the human connection, or it creates friction. Thanks for listening to The Architecture of Healing. If this episode gave you something to think about, share it with a colleague in healthcare leadership, design, planning, or strategy. And be sure to subscribe, leave a review, and continue the conversation as we explore how healthcare spaces and systems can better serve the people who depend on them. Want to learn more? Keep the conversation going and head on over to thearchitectureofhealing.com. We've got more great conversations on the way, but until then, keep shaping the future of care through thoughtful strategy, smart operations, and purposeful design.